Welcome, everybody. This is the Rotary E-Club of Silicon Valley. Every week, we bring you the stories of people who are making the world better. They're improving communities in small ways, large ways, global ways, local ways, digital ways. It's something that we take a lot of pride in as part of Rotary International. What we look to in ourselves is service above self. That idea that there is joy and meaning that come from making others' lives better. Rotary International is 1.2 million people in 36,000 clubs around the world. And all of us are in that space of how can we be inspired by cool things happening here, there, and everywhere. And to that end, we have a program today that we're really excited about, not simply because it is a wonderful effort, but because it represents a wonderful collaboration that we will get into in detail as we get farther into the program. In order to introduce our speaker, I would like to introduce a friend of the club and a member of the Los Altos Rotary Club here in the Bay Area of California, Bruce Fitzgerald. Bruce, I'll hand it over to you for the introduction.
Well, thank you very much, and thank you to E-Club Silicon Valley for the time this morning. We're excited at Rotary Club of Los Altos to partner with One Heart Worldwide on this project. And could we go to the next slide, please? We have been working, Los Altos Rotary has been working in Nepal for almost 30 years. We have a great relationship with the Kandapur Rotary Club, the host club on this project and for a number of our previous projects. And we have partnered with One Heart Worldwide for almost 10 years now. So we're excited to welcome Margaux from One Heart Worldwide to share a little bit more on this project.
Thank you, Bruce, and thank you so much, Rushton and the Silicon Valley E-Club for having me. Like Bruce said, my name is Margaux Charpentier, and I'm the grants manager at One Heart Worldwide. So One Heart Worldwide, we've been working for over 20 years to make pregnancy and childbirth safer for mothers and children around the world. We've been working in Nepal since 2010. And since that time, since beginning our work in Nepal, our program and our intervention has reached about 1.5 million mothers and infants across the country. So we're really, really pleased with the progress of our work, and we're always looking to continue and grow and scale our program some more. So the main reason that we work in Nepal is because the maternal and neonatal mortality rates are higher than in most other parts of the world. So in Nepal, there are about 900 preventable deaths of mothers and pregnant women in the period of pregnancy, childbirth, and the postpartum period. 1 in 10 of these deaths occurs among adolescents because the rate of adolescent pregnancy is also quite high in Nepal. The neonatal mortality rate, so when infants die before reaching 1 month of life, is around 21 out of every 1,000 live births, which is about 12,000 preventable deaths per year of infants. That particular statistic has not budged in a recent decade, which means that we're coming up with creative solutions to try to address this issue. Most of these deaths, the vast majority of them, are preventable if a mother and an infant have access to a well-trained healthcare provider during pregnancy, during childbirth, and in the postpartum period. So in Nepal, there are a lot of issues and barriers to why women do not have access to high-quality healthcare. One of them is limited human resources, so there simply are not enough qualified nurses who are trained in childbirth and on maternal and infant health. The work conditions are really challenging. They're in really remote rural environments. They have limited access to medical supplies and equipment, high quality equipment, and that can lead to high turnover among the nurses that are already trained. For those skilled birth attendants who are trained, we have been finding that their training is not effective to prepare them for real world scenarios. So most of the time, the way the system currently works is a skilled birth attendant might undergo a 3-month training that is book-based, which doesn't prepare her for a live woman dealing with a real complicated situation in real life. As a result of that poor quality of training, the nurses might have lower confidence when they're faced with that situation as well. When a skilled birth attendant is trained, there might not be anyone to give follow-up education or follow-up training after the fact, which means that she might not retain some of the skills that she's learned. Sorry, my cat is joining us for this Zoom call. And lastly, because of where these nurses are working, professional isolation is a really big issue a lot of the time. So they're working in really rural environments, up in the Himalaya, up in the mountains, and they might not have any other nurses to talk to about the type of work that they're doing, to receive training from, or share ideas with other nurses. And as a result, there's not much of a professional network for those nurses to lean on when they are having problems or struggling with their work. So the solution that One Heart Worldwide has come up with, in partnership with our collaborators at the government of Nepal, as well as Laerdal Health Foundation, we have developed what we call the simulation-based mentorship program. And so this program aims to take the theoretical learning that skilled birth attendants currently have and instead replace it with a much more hands-on, realistic practice that nurses can use to learn how to safely deliver babies. So the first step in this program is that we train a number of healthcare professionals who are already working in the maternal and infant healthcare space. We train them as master trainers so that they will be the instructors who carry out the program and who teach the program. Then we set up what are called simulation laboratories or labs in relevant district hospitals, as well as local health facilities that might have a high population that they serve. And so we equip these labs with practice mannequins and medical supplies. So these are mannequins that simulate a birthing woman, a breastfeeding woman, or an infant. And the mannequins are really high tech, so they can simulate things like postpartum hemorrhage, contractions. They've got an umbilical cord. You know, it's like a live baby, not alive, but like a realistic baby doll inside what looks like to be a woman's uterus, and it's attached with an umbilical cord. So the nurses practice the delivery of the baby out of the uterus, cutting the cord, cleaning up the baby afterwards, etc. Like I said, we also furnish them with actual medical supplies. So, you know, scalpels and sutures and all those different things. And the nurses practice sewing of sutures or cutting the umbilical cord, like I said, and all of the other relevant skills that they need using real equipment that they would use in an actual birth scenario. So once these labs are set up and once we have the master trainers trained, the master trainers conduct regular training workshops for the nurses in their health facilities or in the hospitals where they work. And we use what's called a low dose, high frequency model. So you don't want to saturate the nurses with tons of information all at once. Instead, it's steady every couple of weeks, every month, steady workshops over time that A, don't saturate the nurses, but B, give them time to practice the skills that they gained in a workshop in a real life situation afterwards, and then they can come back to the mentor, to the master trainer later with questions that they have. We also place really high importance on collecting feedback from program participants because we're always looking to improve the program. And at the end of the day, this is a program for them and to benefit them. So we always want to hear their perspectives, what's working, what's not. So we organize regular review sessions that they can do this. And lastly, when we go into the health facilities and set up these labs, and when we go into the communities and train these master trainers, we do it in partnership with the Ministry of Health and Population in Nepal. And when we do that, we only agree to set this program up in municipalities that have agreed to maintain the program after we're gone. So we're happy to make the initial setup investment of the program, but the actual maintenance of the program continues after One Heart Worldwide exits a district, a Nepali district, which is after 6 years. And then after that point, the municipality is able to maintain the program on their own. These are just some of the essential topics that nurses learn about during the simulation-based mentorship program. Antenatal and postnatal care, neonatal resuscitation is a really important one. Birth asphyxia is one of the main causes of infant death in Nepal. And it is manageable when you have a skilled birth attendant who knows how to address that issue. Preeclampsia and eclampsia, which are common contributors to maternal mortality. And really importantly for where we work, skills specific to remote areas. So if a patient is in a really rural area and the nurse knows that she can't get her to the hospital in time for a more robust intervention, we train the nurses on what they need to do to save that patient. Okay, just really quickly, we've got a lot of results to demonstrate the positive impact that this program is having. So before we decided to scale it nationwide, we did a pilot study on in 4 program districts, and the nurses that we studied with the pilot of the program, their clinical skills improved by 51%, their knowledge scores improved by 23%, and their confidence increased by 11%. And most importantly, they also reported that they really benefit from the professional network and the mentorship component of the program. So we're currently, thanks to those positive results, we're currently scaling this program up all around Nepal. Between 2025 and 2026, we want to onboard an additional 7 districts. We've already got it in 9. And by 2030, we're going to have a total of 26 districts covered. In total, we expect this program will benefit, In total, we expect that this program will benefit around 144,000 mothers and infants per year. And in 2025, we hope it will reach around 16% of the pregnancies nationwide. The total budget for this program that we are seeking from Rotary clubs, the program is ongoing and it's massive, it's all around the country, but the specific project that we're currently collaborating with the Rotary clubs is about $99,000. And here you have a list of all the different Rotary clubs that have made contributions so far or made commitments so far. And that is a brief summary of the program. I'm going to turn it back over to Rushton and see if there are any questions about the program. Thank you all so much for listening and for being interested in supporting this project.
Excellent, Margaux. Thank you so much. What we'll do is we'll go ahead and have you stop sharing slides for a minute. I'll introduce the people who we have on the recording, and then we'll get into the questions for the group. So when I call your names, please wave. Joining us from the Los Altos Rotary Club, Karen Brenner, who is currently in Turkey with our treasurer, Cecilia Babkirk. Both attended the Rotary International Peace Conference last week. Way to go, guys. And also, of course, from the introduction earlier, Bruce Fitzgerald of Los Altos Rotary Club. Good to have you, sir. From our club, we also have in the San Francisco Bay Area, Christopher, and on Catalina Island, Ernie, and in Houston, Texas, Rory. My name's Rushton. I am in San Jose or San Mateo, depending on time of day and day of week. And it is so much fun to be able to really dive into the weeds on what is a remarkably well-structured program. It's exciting to me to see the kind of data that you bring to it. I'd like to zero in on a couple of pieces as we get into the questions. The first is you mentioned that there's about 12,000 newborn deaths each year in Nepal. That 12,000 represent, and if you said this, apologies for my missing it. How many per thousand?
Yeah, neonatal mortality is measured out of how many infants per 1,000 don't survive the first month of life. So in the case of Nepal, it is 20, did I say 21? Yes.
21?
Yeah. So it's 21 out of every 1,000 babies born in Nepal don't survive a month. And the goal for the SDGs, the United Nations Sustainable Development Goals, they want to bring that down to 12 per 1,000.
I believe that represents about 10 times the newborn rate of mortality here in the United States. I think it is about 2.1.
That sounds about right. Yeah.
Okay. So in thinking about your organization's work, by the way, all good about the CAD, don't worry about that. In thinking about your organization's work, there are the areas in which you have trained skilled birthing assistants, right? And then there are the other areas. So do you already have data about maternal and newborn mortality in the areas where you are running this program, or are we kind of too early on that?
Yeah, so actually One Heart, it's a good question to ask. One Heart doesn't measure mortality of mothers and infants as one of our indicators because there are so many factors that can contribute to mortality that it's really hard to point to our intervention as like the one thing that had an outcome on it, A. B, while of course the numbers are staggering, 900 women, 12,000 infants, whatever, particularly in the case of maternal mortality, it's actually relatively rare, right? Because like if Nepal is having 600,000 pregnancies a year and 900 women die, of course that's too many, but it's kind of a small sample size to really get an accurate, to get accurate data on those changes in such a short amount of time. And so what we do is we just depend on the government of Nepal's Ministry of Health and Population and the statistics that they collect in their census and in their health management information systems. So we don't independently measure mortality in the areas that we work. We rely on the government statistics. And like I said, there's so many NGOs working. The government is doing its own interventions. There's lots of different factors just in terms of like socioeconomic development. Perfect example. The roads in Nepal have been getting better in recent years. So 15 years ago when we started working in Nepal, the roads were absolute garbage and you couldn't get a woman who is in a difficult birth, you couldn't get her to a referral hospital quickly and she might have died on the way. Now the roads are better and she can survive that birth, right? So we can't point to our intervention as like the thing that solved that problem for her. And we can't point to any one particular factor as the panacea for this problem. So all we do is we just take the government's data and we look at that over time. And we think that we are one part of an overall system that is working to improve maternal health in Nepal and infant health.
Point well taken. One of the difficulties of discussing data about anything along these lines is that challenge of the multitude of variables. Similarly, there's a multitude of benefits. So in that you are training skilled birthing assistants to help women as they're going through their pregnancy, as they're delivering their children, and things like this, there have got to be a range of other benefits for those women, those families, those communities. And can you recap some of those pieces so that people understand that the kind of stuff we're doing is not just about trying to get a number from, say, 900 countrywide to some lower figure, that there is this range of benefits for your work.
Yeah, absolutely. So one of the main issues in Nepal that we're working to overcome is a lot of women don't seek medical attention when they're pregnant or when they're in labor or afterwards, right? And these are all things that in the West, women absolutely go to the doctor multiple times, but once they find out they're pregnant, they go to the doctor multiple times. They have lots of follow-up appointments. You give birth in a hospital most of the time, and then you go to appointments to check on the newborn and get yourself checked out in the postpartum period, right? And in Nepal, that's not, in a lot of the places that we work, that's not part of the culture. And so what we do is we work to overcome those barriers. We ask, why don't women go to a health facility? And there are a lot of reasons. One of the main reasons is that they don't feel the health facility is safe. They don't trust that the nurse working at the health facility has the skills required to help them. So they might say, well, my mother-in-law has 5 kids, so why doesn't she help me deliver at home instead? Right? She's more trusting of a home birth than of a health facility birth. They might not be aware of the need to go to a health facility. If they've got a pregnancy that they feel is progressing normally, they might think that there's no need. I feel fine, there's no need, right? And so what we are aiming to do by training these skilled birth attendants and by and this isn't the only thing that One Heart does, by the way. We have a number of interventions that are all designed to get more women into health facilities when they're pregnant. But what we're aiming to do is to convey to them the importance of getting checked out at a health facility, attending those prenatal doctor or care appointments, because they're not seen by doctors, they're seen by the nurses. Training the nurses to recognize issues that might need to be referred to a larger hospital. And also, I mean, and this is so simple, but one of our main interventions is that we counsel women on the importance of saving up a little bit of money in case they need to get to a hospital during the birth. So the transport costs, like I said, the communities where we work are really rural. So you might be in labor and the nurse might say, hey, you're having complications, you need to get to the hospital. And the mom might say, I don't have the funds to pay, someone to bring me in their truck to the hospital. And so one of the things that we do is be like, hey, the entire time that you're pregnant, just put a little bit aside so that if you're in that situation, you have a way to get to the hospital. So lots of different, outreach activities that we do just to try to increase demand for our healthcare services and encourage the women to seek out those services.
So I'm struck as you describe that. I think back to the very powerful presentation we have had just recently from Dr. Donna Adams Pickett in Georgia, and the work she is doing with mothers, neonatal healthcare in rural parts of Georgia, and there's all sorts of places in the United States where here's the rate of maternal and newborn mortality in the cities, and here's the rate in areas that are an hour at least from the nearest hospital and things like that. I would guess that the data probably point to exactly the same kind of thing in Nepal. So can you talk a little bit about how you chose the places that you chose for the work that's happening through One Heart Worldwide?
Yeah, absolutely. That's a great question. And it comes down to exactly that issue. So everything we do in partnership with the government of Nepal, with their, it's the Family Welfare Division and of the Ministry of Health and Population. And so there are 77 districts in Nepal. That's just how Nepal is divided. They're across 7 provinces. We're currently working in 5 provinces. And when we started our project in Nepal, we basically did a needs assessment in conjunction with the government partners to say where are the areas with the greatest need. So for example, we don't work in Kathmandu because we don't have to. We tend to not work in the large cities because in the large cities, there are hospitals. So there's roads for women to get to the hospital. There are hospitals with doctors who have adequate equipment. And in general, in the larger cities, there's a higher level of education. So women are completing high school a lot more. The literacy rates of women are higher. And there's a direct correlation between a woman's literacy rate and her likelihood of seeking out healthcare when she's pregnant and delivering in a health facility as opposed to at home, right? So the areas that we decided to target after looking at all the numbers and seeing where's the greatest need are areas with really low female literacy rates, low rates of women completing secondary education. Where we work, there's a lot of subsistence farmers. So it's a higher than the national average percentage of people living below the poverty line. It's not always necessarily rural, particularly where we work in Madesh. It's a very populated area. But there are a lot of different socioeconomic and cultural factors that contribute to women not seeking healthcare in those areas. So we decided to work there as well. So anyway, when we first started our original mandate, I'm sorry if I said 32, I meant to say 36. So we outlined 36 districts that appeared to have the most need with the government of Nepal. And we have a project agreement with them to work in those 36 districts. And now the thing is we're only in a district for 6 years. So we're able, as we transition out of a district, we onboard more, right? So we onboard 4 every year and we transition out of 4 every year, roughly. And now we're approaching the end of our original mandate of 36 districts, and we're looking at adding on another 10 in a 6th province. Because again, we looked at the numbers and we were like, okay, there's a need there. So.
Nice. So let's turn to the relationship that you have with not just a series of Rotary clubs, but specifically the Los Altos Rotary Club. As viewers may or may not know, as listeners to the podcast may or may not know, Rotary does outreach to all sorts of social benefit efforts all over the world. And one of the ways that happens is through what are called global grants. These are anchored by a host club. You mentioned the club in Nepal. Happy to get a shout out to them again. And then there is a club that submits the proposal. This is the Los Altos Rotary Club, and other clubs contribute to helping make this happen through the different mechanisms of Rotary International for essentially multiplying, the funds that are going into the effort. And so, Karen, what I'd love for you to do is to unmute and to talk to us a little bit about Los Altos Rotary Club and how and why you're connected to One Heart Worldwide.
I'd love to. Thank you for the opportunity. When I joined Los Altos Rotary Club in 2016, I met a gentleman named Allert Leitenberg, and he'd been to Nepal 30 times at least. And he just was such a big proponent of helping the community and build up the healthcare and emergency relief after earthquakes. And he just was very active and did a number of grants over the years. And he connected us with One Heart Worldwide. And it's just been really good to see all the good that can happen there in such a needed community. And we did a prior project that he had led and I helped with prior to Margaux coming on to One Heart Worldwide, that we had partnered with One Heart Worldwide to get rebuild and equip 16 birthing centers in the northeastern part, very rural areas of Nepal. And as Margaux was saying, it took days to get there, just walking or various types of transportation, climbing over logs. It was just not easy. So the birthing centers were very critical to saving lives. Sorry about that. And making sure that the women had help and the babies had help to make their lives a little bit better, understand what the risks are. And that project is wrapping up now. We're rolling out this one. Because we also trained skilled birthing attendants in that earlier project. And when we did that, the follow-on is what Margaux is referring to in this new project, is giving them additional training. They felt like they got really good training out of it, and they were able to assist where there was no care before, which is great. But we also need to bolster their confidence because as Margaux referred to, the Ministry of Health and One Heart Worldwide had figured out that these skilled birthing attendants were feeling very isolated and very unsupported in a way that they needed to be in order to perform their duties, in a way that they felt comfortable and that was helpful to the community. Now, I think that this project in particular, we've been very fortunate to be able to get, sorry, there's people talking in the background. I'm a little confused. This project in particular has been really great because we've gotten the support from clubs like yours to make this a success. We're hoping that Margaux can probably speak a little bit more about the impact that it's had on the communities where it is right now, and the communities where she's going into, and what we can expect in terms of how the people can believe in more care is better for them to receive, the life-saving care that they need. Sorry, I'm a little distracted with all this.
You're just fine, and the whole thing of getting the chance to tell the story about what has happened among these different partners is a joy regardless. And so Margaux, a little bit about that. You have Rotary effectively as a partner, given that you have these specific Rotary clubs as partners. What is it that works especially well, if there is such a thing, that makes Rotary a particularly useful partner for the work that you do?
Yeah. So I will say this is my first ever project with Rotary partners. I've been at One Heart for 2 years. And so the previous project that Karen was referring to was before my time. But as since I started working with Karen and Bruce and Cecilia, and as we've been working through this grant proposal period and what I can see is going to happen when we eventually start executing the project, For me, the most valuable component appears to be Rotary's involvement in the project. So you ask the right questions. They're asking really good questions about how many people are we going to reach? How is this going to change lives? What outcomes can we expect? And then the involvement of the host club in Nepal, they're actually going to go to our project sites and like see it for themselves, right? And so I think that level of involvement where the funding partner is upfront and personal with the issue and really seeing and understanding the issue, I think that level of awareness, it brings a lot of value to the project.
And if I may add, our partner in Nepal, he wants to be very active. He works on all the reports. He asks, and Margaux drafts things, and he's like, well, wait, I want to be involved in that too, all the time. So he's like, I want to be in the equipment procurement process. I want to be this. I want to be that. So he's just excited to be there, and it's just really refreshing to work with people who are so motivated to make change.
Nice. Well, and I think that's probably a really good place for us to wind down the recording. Before I hand it back to Margaux for the final word, let me tell all of our audience this. By participating in the live recording, not only do we get this chance to have Q&A as a part of what you see and hear, but we get to talk to these people afterwards. So there, that opportunity to really connect with people making a difference in the lives of others everywhere is something really special about being part of these recordings. So with that, Margaux, I'd like to hand it back to you for the final word. What would you like people to have clearly in mind as they finish watching the video or listening to the podcast?
Yeah, thank you. I'm so grateful for the opportunity to be here. Thank you so much for inviting me to come and speak about our work. And I think the main takeaway that I want people to understand is that these deaths and these poor outcomes for pregnant women, for new moms, for babies in Nepal, they're preventable, right? And they're preventable not with expensive, high-tech interventions, not with major structural overhauls of the Nepali healthcare system. They're preventable with really simple interventions, like the mannequin that we are going to use to train nurses costs like $400, right? That's a low-tech solution. And one nurse who's trained like that will keep those skills for her whole life and impact every woman and infant that she works with throughout her career. So I think just the preventability of the issue is what I want people to take away.
I love that. Margaux, thank you so much. Karen and Bruce, thank you as well. And everyone, we will see you next week.